neomercazole or giving radioactive iodine. So that's the use of a very simple technetium thyroid scan. All of you come across patients coming with swelling of the leg. You want to know whether it's a lymphatic edema or is it a venous edema. A Doppler study done with ultrasound is an excellent modality to rule out whether there are incompetent veins, whether there's any thrombosis of the veins causing edema. But many times it may be difficult, even for a sonologist, to distinguish between the two. That's where we come in. What we do is a test called a lymphangiogram. We inject this isotope in the web spaces of the feet. You can see the injection has been given here. And then we trace the path upstairs. As you can see, the initial images, you can see the lymphatics very clearly demonstrated bilaterally, and the nodes are picked up very well. So in a normal lymphoscintigraphy, you will see bilateral visualization of the lymphatics in the early stage and a good symmetrical uptake of lymph nodes. If you get such a picture, you can exclude lymphedema for all practical purposes. As opposed to this, you have a patient here who's got a swelling on the left side of the leg. You can see you're hardly seeing any lymphatics here. You're not seeing any lymph nodes here on the left side. While on the opposite side, you're seeing the lymph nodes very nicely, and you're seeing the lymphatic vessels picking up. So there's a clear-cut lymphatic obstruction in the left lower limb over here, and the site of obstruction is in the inguinal region. Simple study, just takes about 2 hours. It gives you the diagnosis whether lymphedema is there or not, and it also tells you the site of obstruction. Many patients come to you with a bloated sensation in the stomach. You have done gastroscopy, found nothing. They say there is pain, fullness. You want to know whether you are dealing with gastroparesis. Simple study, we make them eat radioactive meal. Literally in our department, we make a radioactive chapati with a thing called sulfur colloid, and the patient eats it, and then we look at the gastric emptying time. You can see here the stomach is full of this radio tracer, and as time goes by, there's hardly any emptying of the stomach. All the tracer is remaining right up to 1.5 hours, and this curve shows a flat pattern. Now this patient has an impaired gastric emptying, a prolonged gastric emptying. Normally around 1 hour, most of the tracer is gone from the stomach. T-half we call it. Half the activity is gone. But in this patient, you can see the T-half is 370 minutes. So you have a very simple objective test documenting gastroparesis, and if you treat them with prokinetics, you can show a dramatic response. Of course, clinically also, you'll say that patient feels better. Why do I need to document it? But in difficult cases, this is very simple test to show you objectively that there is indeed a significant movement disorder of the stomach, and you have an objective test to document it. Pulmonary embolism, all of you know, patient comes to you with acute breathlessness. A simple study, a lung perfusion scan. You inject microaggregates of albumin, you see a lot of perfusion defects here. These are called Q scan, is perfusion scan, multiple perfusion defects. Then we do a ventilation scan. We make the patient inhale a radiotracer, and we find that the ventilation scan is normal. So combination of an abnormal perfusion scan and a normal ventilation scan is pathognomonic of pulmonary embolism. Nowadays, CT angio has come in a big way, and it has almost replaced the ventricular perfusion scan, but it is replaced not because of better sensitivity, it is replaced because of better availability. You will find CT scanners in every nook and corner, but a nuclear medicine center requires a lot of regulatory issues, a lot of permissions. But sensitivity and specificity wise, this scan is as good or even slightly better than a CT scan, because CT scan is showing you the thrombus, this is showing you the effect of the thrombus. And many times, if your learning curve is slow, many pathologies look like thrombi. So you have to have an extremely well-trained CT scan specialist, otherwise you can end up with a lot of errors in the diagnosis of pulmonary embolism. Gastric paresis, I've already told you, many patients come with pain in the hypochondrium. You have done ultrasound, no stones. You have done endoscopy, nothing. What are we dealing with? There is a group of disorders called biliary dyskinesias, which are very easily diagnosed using nuclear medicine techniques. What we do is do a study called a HIDA scan. This is a scan which shows hepatobiliary transit. We inject it into the veins. You can see now the tracer is come into the common bile duct, it has come into the gallbladder, and when the gallbladder progressively fills up, we give a fatty meal, or we give a cholecystokinin infusion. After fatty meal, the gallbladder should empty dramatically. If like this, in this particular case, post-fatty meal, you can see, pre-fatty meal, it is full of radioactivity, post-fatty meal, it is emptied. The gallbladder ejection fraction is almost 90% here. So if you find in a patient who's got postprandial discomfort, an ejection fraction post-fatty meal to be less than 40% or 50%, you know you're dealing with a biliary dyskinesia. The ultrasound may not show any stones, it may not show any thickened walls, because the pathology here is not anatomical. The pathology here is less presence of cholecystokinin receptors in the neck of the gallbladder or in the gallbladder wall, and therefore the gallbladder doesn't contract, or if it contracts, the cystic duct doesn't, the sphincter doesn't respond, doesn't relax, so you get pain. So a impaired gallbladder ejection fraction demonstrated on a scan is hallmark of biliary dyskinesia, and these patients will probably do better with a cholecystectomy. The major role of nuclear medicine nowadays in clinical practice is in ischemic heart disease. You want to know if a patient has got chest pain, does he have obstructive coronary artery disease, how severe is the disease, what is the chance of this person getting a heart attack. You are of course going to do an angiogram. You say, why do I need a nuclear scan? I'll do an angiogram, I will see the blockages. If I see the blockages, I'll open them. This has been the sort of way to deal with the coronary disease so far. But we are realizing increasingly that this is not the right way to go. Anatomic abnormality on a coronary angiogram has to be accompanied by a physiological abnormality on a perfusion scan to make management decisions. If you have a normal anatomy, if you have triple vessel disease, abnormal anatomy, or a two vessel disease or a single vessel disease, 70% LAD, it's 75% circumflex. If I do a myocardial perfusion scan, and if I show that the myocardial perfusion scan is absolutely normal at a very high degree of exercise and not accompanied by significant ST changes, you will not treat this patient with intervention. Only if the coronary anatomy, abnormal coronary anatomy is accompanied by an abnormal physiology in an abnormal perfusion scan, only these patients should be intervened with angioplasty or a bypass. But if the myocardial perfusion scan is normal, then you will manage them medically. And this point has been very, very vehemently proved in all these past studies, like the Courage trial, the FAME trial. It has been shown that decisions made by a combination of anatomy and physiology are better than decisions based on anatomy alone. In the FAME trial, if you had a stenotic coronary artery disease and you opened it without looking at the physiology in one group of patients, in the second group of patients, they had an abnormal coronary anatomy. They also did fractional flow reserve, a physiological test. Those who had abnormal fractional flow reserve and abnormal coronary anatomy did very well with interventions. Those who had normal fractional flow reserve and a stenotic disease did not do better with interventions. So this point has been very clearly demonstrated that to make correct management decisions, only anatomy-based approach is no longer valid. It has to be accompanied by a physiological test also. And this has been shown that if you have a normal myocardial perfusion scan, the chance of your heart attack or cardiac death is very, very less. As opposed to that, if you have a severely abnormal myocardial perfusion scan, the chance of you having myocardial infarct or death is 4 times what is in a normal population. So we use a myocardial perfusion scan for risk stratification. It acts as a gatekeeper. A normal or a mildly abnormal myocardial perfusion scan, good prognosis, aggressive medical management, whatever the coronary anatomy. An abnormal myocardial perfusion scan, bad prognosis. Medical management is not going to be as good as interventional management. And you can see from this slide, as the a percentage of myocardium which is ischemic, we can quantify you how much percentage of the myocardium is ischemic on our scan. When it goes beyond 12.5% of the myocardium is ischemic, then it is clearly shown that revascularization strategy is much better than medical management alone, because the incidence of mortality is higher with medical treatment as compared to surgery when the amount of ischemic myocardium is large. So we can tell you how much is the ischemic myocardium, and you can make your correct management decisions based on that. Here you have a patient who's got a big perfusion defect here. You can see this inferolateral wall. On stress, on rest, there is no improvement at all. This was a person who had a heart attack. And the question was, is the heart viable? Is the muscle in the infarcted zone viable? This is where we have a test called viability PET. As you know, we inject radioactive glucose. Glucose is the fuel for all live cells. Myocardium, myocytes which are alive, lap up glucose because they have to contract. Dead myocardium cannot pick up glucose. So glucose uptake is an indicator of myocardial viability. So you see here, we have done a viability study with fluorodeoxyglucose. There is absolutely no uptake in this region. So we told that cardiologist that this is all dead myocardium. There's no point in doing the revascularization. But naturally, they still went ahead and did the revascularization. And when we did the post-PTCA, post-percutaneous coronary intervention, there was no improvement at all because the muscle was already dead. And what you did was opened up an artery which was supplying dead muscle. So the only person who benefited from this procedure is the cardiologist and not the patient. As opposed to this, you have a patient who's got a severe defect in the stress on the anterior wall septum. When we do a glucose scan, you see all this is viable. The defect is picking up glucose. That means the muscle there is still alive. So when you do the intervention, you open up that artery, you see that post-intervention, the muscle has come back to life. Perfusion has improved and the muscle is all. So to make decisions regarding revascularization in a patient who's got a massive infarct with a poor ejection fraction, it is now mandatory that you do a test, either a myocardial viability test using FDG or an MRI to find out whether the muscle is viable. Now FDG is supposed to be the gold standard. MRI is also an excellent study to look for myocardial viability, but it requires a lot of expertise, a lot of time to be spent. But in FDG, it's all or none. Uptake is there, it's viable. If there's no uptake, it is not viable. Then we come to a very new and exciting test which we have introduced in the country for the first time. It is called a dopamine transporter scan. All of you are aware of Parkinson's disease. A person who becomes old starts walking slowly, shuffling great, he gets a little tremor, he becomes a little akinetic, a little rigid. Question is this all old age changes or is it Parkinson's disease? It is important to make this distinction because if you diagnose Parkinson's disease, then you are committed to a lifelong treatment with dopaminergic agents which have their side effects. What we measure is this dopamine transporter. We have an agent called technetium trodat. We inject it into the body and it images the dopamine transporter. In Parkinson's disease, there is a deficiency of dopamine transporter in the caudate nucleus and putamen. What you see here is a normal caudate nucleus and a normal putamen on both sides. They look like commas. And this was my brain. You can see at the top, I was the first guinea pig when we started this study. And this is how a normal study will look like. Bilateral, symmetrical dopamic tracer uptake. As opposed to that, you have here a 50-year-old male with a history of antipsychotic drug medication, demonstrated clinical features of Parkinsonism. You know, many times antipsychotic drugs have Parkinson's-like symptoms as side effect of the drug. But it is important to know whether he's got Parkinson's disease or is it a drug-induced Parkinson's-like picture. So when we do this trodat scan, you can see that there is a significant reduction in the uptake of dopamine transporter on the left side putamen. The left caudate is very nicely seen. The right caudate is very nicely seen. So is the right putamen. But the left putamen shows deficiency of dopamine transporter. This is pathognomonic of Parkinson's disease. A unilateral, asymmetrical reduction in the putamen of dopamine transporter. There is no differential diagnosis. This is Parkinson's disease. On the other hand, if it was like my brain I showed you earlier, symmetrical dopamine transporter expression, it excludes Parkinson's disease for all practical purposes. In fact, about 20%, as high as 15 to 20% of patients who are clinically diagnosed as Parkinson's disease with all the clinical features, when they do a trodat scan, they are normal. 15 to 20% of clinically diagnosed Parkinson's disease have normal trodat scan. And when they are followed up, they do not progress. Parkinson's disease is a progressive disease. It has to progress as time goes by. So 15 to 20% of the patients will be wrongly labeled as Parkinson's disease if you go by clinical criteria alone. Therefore, this scan has come as a boon to the neurologist to distinguish Parkinson's disease from Parkinson's mimics, which are many, like drug-induced and various other pathologies. Now, last few slides, I will talk to you about this new exciting modality of positron emission tomography, which has come in a big way. What we use is radioactive glucose. Glucose is the petrol for the body. It is a fuel for all the cells. They lap up glucose. There are glucose transporters which are expressed on the cell surface. They pick up the glucose. Glucose is taken in. It is metabolized and converted into energy. Fluorodeoxyglucose is an analog of glucose. It enters the cell and remains trapped there. It doesn't undergo metabolism. So all inflammatory cells, malignant cells, and infective cells, they all pick up radioactive glucose. So malignant cells especially pick up glucose 5 to 10 times more than normal cells. So when we inject radioactive glucose, we pick up foci of abnormality, which could be malignancy, which could be infection, which could be inflammation. So you have a very sensitive method of picking up disease wherever in the body it exists. This is how a normal FDG glucose looks. You know, the brain is a very metabolic organ. It consumes a lot of energy. So brain looks the hottest. Next is the heart. It's pumping all the time. It requires energy. So the heart is also the hottest. Then this is all urinary bladder. This is how a normal FDG PET looks like. I'll show you a few examples. Here is a 62-year-old female who had fever since 1 month. She had weight loss, muscle pains, no localizing signs. Very high ESR, ultrasound, X-ray normal. This is the situation which we always come. Pyrexia of unknown origin. They are sent to us for doing a PET scan. And what do we find on this PET scan? Intense uptake of glucose in all the major arteries. You can see here the common carotid, the subclavian, abdominal aorta. This was a case of vasculitis. There's an inflammation of the large arteries all over the body. And this is the only modality which tells you with great certainty that you're dealing with a vasculitis. Only abnormality was a high ESR. Steroids were given and she made a dramatic response. So nowadays it has been found that PET-CT using FDG is a very powerful modality for patients of fever of unknown origin. And it is now being recommended as the initial cost-effective test in this group of patients. There are several studies now. I quote you just a smaller one where we are able to tell you the focus of infection in a large number of cases. And those patients who have PUO and who have a normal FDG PET study, their prognosis is excellent. They usually turn out to have a diagnosis of drug fever or a non-focal systemic infection. Most of them do complete recovery. Mind you, when they come to us for a PET-CT, they have already undergone CT of chest, thorax, abdomen, pelvis, ultrasound, cultures, everything possible, and spend a lot of money. Instead of that, you do one test which gives you a full diagnostic CT, head, thorax, head, abdomen, pelvis, brain, as well as the physiological FDG uptake. So we have a very powerful and a sensitive method to find out the cause of the pyrexia of unknown origin in a single step. Here was a 82-year-old male with low back pain since 20 years, worse since the last 15 days. He had history of urinary tract infection. His ESR was very high. He had a pacemaker. So we could not do an MRI for him because he had a pacemaker, but his fever was there, backache was there. So we did a PET-CT. What do we find on PET-CT? You can see over here where the cursor is. There is an intense uptake of FDG in this intervertebral disc space, L4-5 region. And you can see on the sagittal section, this is the CT image, this is the PET image, this is a fused image. So we told them that there is a focus of infection there. They did a biopsy, it showed a caseating granuloma. Patient was put on anti-COX treatment. You can see here on the right side, pre-AKT, you can see that lesion is there over here, and post-AKT, the lesion has vanished. So we can show you a focus of infection, inflammation or malignancy. You can treat it, and you have a good response to your therapy. I'm showing you 4 or 5 examples now before I conclude. Here is a brain PET. You know, brain, as I told you, metabolically active. This is how a normal brain PET looks. Good uptake all over the brain. All of us suffer from memory loss. You keep on forgetting keys. Sometimes you forget your wife's name. We wonder whether we are developing Alzheimer's disease. There is a condition called age-associated memory impairment, which all of us are going to go through. And then comes a more serious condition called mild cognitive impairment. And then comes the worst of all, Alzheimer's disease. Now, how do we distinguish between the two? A PET scan is an extremely useful modality to say whether you are going to suffer from Alzheimer's disease or not. If you have a person who's losing memory, if you do a PET of the brain, if it is completely normal, you can assure him you're fine. You don't have any problem at all. If he has a very mild abnormality in a parietal region, you can see this is called mild cognitive impairment. With a mild cognitive impairment patient with abnormality, red flag is raised. These patients are likely to develop Alzheimer's disease as time goes by. In a classical Alzheimer's disease, we start seeing a typical bilateral parieto-temporal hypometabolism. And in the late Alzheimer's disease, the whole brain becomes hypometabolic. Here is a 65-year-old male with loss of memory. And he was sent to us to diagnose whether he's got Alzheimer's disease or not. I'm showing you on this right side how a normal brain looks. While here you can see there's a severe bilateral parieto-temporal hypometabolism. This is pathognomonic of Alzheimer's disease. If you have this picture, no differential, you have your diagnosis. If it is completely normal, you can assure the patient you are not having Alzheimer's disease, enjoy your memory loss. Sometimes it can be beneficial. Here you have a patient who came with a seizure.